Good evening, everybody, ladies and gentlemen, dentists and students. Thank you for coming and giving up your evening with us. My name is Dr. James Tran, and I am here with Dr. Aditya Sawant, and we are here talking about the topic of biomimetic dentistry. Welcome, Dr. Addy.
Thank you very much.
Um, So I'll just do a quick intro and then we'll get straight into it. Hey, Dr. Aditya, is that how you say it? Doctor? We'll just call you Dr. Adi. Dr. Aditya Sawant is a general dentist based in Ballarat and Greater Melbourne, Victoria. Dr. Adi has brought his university experiences in rural New South Wales back to Victoria and enjoys all aspects of general dentistry with a keen interest in adhesive dentistry and oral surgery. Expanding on his interests, he is now a lecturer with Biomimetic Aesthetic Dentistry, otherwise known as BAD, aiming to introduce dentists to modern biomimetic and advanced adhesive techniques. An avid CPD consumer, he has completed close to 260 hours of CPD in the last 2 years across a variety of disciplines. He is currently completing a diploma with the gIDE Implant Institute, as well as his certificate with the General Dental Residency in Clinical Dentistry, for which he is also an ambassador. So welcome back, Dr. Addy.
Thank you very much. All right, let's get this show on the road. So let's see if I can present my screen here.
By the way, everyone, while we're loading up, if you have any questions, please pop it in the chat. There's a little chat window on the right side there. And it's popped on there. And we'll go through all the questions at the end. But if Dr. Addy would like to answer it throughout, then if he has a moment, then he'll certainly do that for you.
For sure. All right, guys. Thanks for joining me on your Wednesday afternoon or Wednesday evening, sorry. Essentially today is all about overlays, biomedics, and adhesive dentistry. Like James said, we've got a ton of slides today, a ton of information to share, but just pop any questions in the comments and we can answer them after, or you can even DM me later, all right? The other thing, just some housekeeping. I still haven't decided what I'm going to give away yet, but tag me, tag General Dental Residency on Instagram. Make sure your profile's public, or just DM me the story that you put up, and I'll probably give away something to 2 people. It's a bit more exciting if you don't know what we're giving away yet. But as James kind of talked about, it's a bit about me. I'm doing all types of dentistry. The number is not quite 250 hours. It's a bit more depressing than that. I'm probably closer to 450 now over the last 2.5 years. But, you know, it is what it is. It takes me to some fun places like Mykonos on the right-hand side and across Australia on the left. The reason some of you are listening to me today is obviously I've done the GDR residency, but I'm now back helping them out. And I'm one of the key lecturers for BAD, which is probably the biggest biomimetic course in Australia. So it's what we're going to talk about today. And we're going to talk about teeth that look like this. You know, how do we treat teeth like this? That's why you guys are all here on your Wednesday evening, right? So what is biomimetic dentistry? Essentially, biomimetic dentistry is just restoring the tooth back to its original form. We want to keep the pulp alive. We want to preserve essential tooth structure. We'll talk about what essential is. And we want to kind of reconnect, because we're dealing with broken down teeth. We want to reconnect these teeth front to back, side to side, top to bottom, right? And the philosophy we hold at BAD, and I'm sure GDR does too, is we want to drill less and we want to bond more. But let's talk about why these teeth are a concern in the first place, right? So cracks are the bane of our existence as dentists. They're a serious problem. And you know, back in the day, before modern dentistry, hundreds and thousands of years ago even, cracks were often a death sentence, right? Cracks are a highway for bacteria, or teeth would split in half, develop pulpitis, infection, abscesses, and there's not really much back in the day that they could do for that. But bigger problem for you and I is they're a big point of confusion, right? These are some struggles I've had in the past. You know, how do we predictably save these cracked and symptomatic teeth? Do we need to do endo? Can they be avoided? Where are they coming from? What crack should I be most concerned about? Can I watch some of them? Do I need to remove every crack? What cracks can I leave? How much do I remove? And how do you kind of successfully diagnose these issues? And it's kind of how we feel, right? A bunch of uncertainty everywhere. Before we go on, there's a couple of inspirations for this lecture. I've got Pascal Magnier on the top left, the Allemans on the bottom left, David and Davey. We've got David Jadol on the bottom right. We've got Graham Milicic, who I'm about to talk about in the next slide. And of course, Bill Gerges, who I'm now teaching with BAD. So the compression dome concept is a key part of biomimetics. And Graham Milicic, in his paper in 2017, really conceptualized this quite well. But essentially, if we look at domes or compression domes outside of dentistry, this is what we see, right? You look at ruins, you look at the ancient Greeks, ancient Romans. A lot of the ruins that you see, these dome-like structures are the last thing that are standing. Why is that? It's because these domes are actually quite strong as structures. If you look here, what they're really good at doing is putting things in compression and dispersing their tension along down the sides. And, a compression dome is just a 3D arch. They're really strong. You can see here we've got two compression domes, quite small, but supported on all four sides, supporting an entire car, right? And this paper at the bottom is, I actually talked to David Alleman about this paper. For some reason, he's obsessed with the surnames of these people, but he'll have a little chuckle every single time. But it's a really good paper about talking about how these forces are dispersed throughout the tooth. And again, more compression domes around. And we've got a compression dome on the right there with a cylinder at the bottom. And the way teeth absorb these forces are very similar. You've got teeth that look much like compression domes as well. If we go back to that compression dome picture, what teeth kind of do is they have the enamel on the top and on the outside, and they've got their dentine in the middle. The top of the tooth is what we call anisotropic. It's when anisotropic forces are when something is pushed, it transfers kind of immediately to the bottom, right? Dentine is much better at dealing with isotropic forces. And essentially that means when something is pushed, it squishes or it disperses horizontally. With traditional crown and bridge techniques, we'll talk about in a sec, a big issue is we're taking those anisotropic forces, they're really rigid forces, and we're putting them down deep in areas which are designed to have a lot of force absorption and distribution. So much like those compression domes, we can see the entire tooth is like a compression dome. Each cusp is like a mini compression dome as well. And because of those evolutionary reasons, teeth have developed to be quite strong. If we look at this video here, you can see it's taking a ton of load. The guy gets real excited in the middle too, in a second. I'm not sure if you guys can hear the audio. And you'll see at the very end, even the mode of fracture here, it's that enamel giving away quite quickly because it's anisotropic. Pretty close, almost 300. And there you go. That's that enamel giving away. And you can see in this image here, we've separated the tooth into a couple of areas. We've got that compression dome structure. We've got some peripheral rims. We'll talk about what those are. And then we've got two key features. We've got the subocclusal ridges and the biorim. And again, Milicic pops up again alongside Tim Rainey, described those moire fringes, that analysis, and these very clear cut essential areas of tooth, the biorim and the subocclusal transverse ridges, otherwise known as Rainey ridges, in the tooth. But essentially, it's not just enamel, dentine, and pulp as three different kind of systems. They're all a complex, or they're all a coherent system that work together. Now, talking about the biorim first. The biorim is essentially, they come up with a lot of these names throughout biomimetics. The reason I've got them in here, so then when you're scrolling on Instagram, you're reading a textbook, you know what we're talking about. A lot of them do tend to overcomplicate things a little bit. That's what this lecture is for. So the biorim is just the 2 to 4 millimeters in the cervical area, 2 to 4 millimeters above the CEJ. If you also look at the tooth from the side, it's the maximum convexity of the tooth. Not sure how many of you made dentures at uni, but if you used a surveyor, those like little machines that you put your model cast on just to run your chalk or whatever on the side to find out that contour line so you can fit your clasp underneath, it's exactly that maximum convexity of the tooth. Anything underneath there is essentially the biorim. And just like the compression dome picture from before, it is that cylindrical structure sitting underneath the arch. And it is essential. It forms the base of the dome, and preservation of that biorim, if possible, is quite important because it's going to allow for that force distribution, that isotropic force distribution that dentine has. What that looks like on a prep is you can see on the left, tooth before prep, on the right, tooth after prep, and that red highlighted area is the biorim of the tooth. A bit more of it is obviously hidden by the rubber dam, but that's essentially what it looks like. And relating back to these dome structures, you can see that red area is the biorim. Now, the other structure we talked about, these rainy ridges. On the left of the screen, you can see that moire fringe analysis. Essentially, those bands you can see up top, they're quite vertical. The stress is going down into the tooth. And along the sides, along the cervical third, you can see that force distribution is going horizontally, right? It's exactly the forces going through a tooth. What these rainy ridges are the kind of subocclusal enamel that runs under the pits and fissures of teeth. They help the tooth connect side to side, front to back, top to bottom. And what happens is, if you look at these dome-like structures as cusp tips, and you've got your fissure enamel in the middle, the skew back is essentially a sloping surface against which the end of an arch rests, right? And when you remove that skew back, you remove those rainy ridges, and there is increased structural collapse of the dome structure. Essentially, in normal speak, it's the occlusal pit and fissure enamel just matters the most. Matters more so than the cusp tips. The tricky thing with traditional dentistry, I'm not saying to throw out Schillingberg's textbook. You may still need it with certain things, but even with the traditional amalgam occlusal fillings, what you've got is invasion of those rainy ridges and removal of those structures. So with traditional GV black type preparations, extension for prevention, those kind of things, you remove those rainy ridges and you get a lot more flexure of the tooth. There's a paper by Magnier and Augensian in 2009. It shows that the normal tooth will flex in the range of around 6 microns. As soon as you just remove those rainy ridges in the occlusal section, those pits and fissures, now it's flexing at around 180 microns. As you can imagine, this increases stress concentrations on these marginal ridge areas here. And you'll see later, those result in potential cracks. Similarly, invading the biorim of the tooth with, for example, a traditional heavy PFM crown preparation, it increases the stresses in the area and decreases that cervical dentine, that biorim that's able to absorb and disperse those stresses. It increases essentially those anisotropic rigid forces all the way down the bottom. And we know that tension equals cracks. Now, pulpal health was one of the other goals that we were aiming for. We already know that a tooth needing a root canal or going through a root canal increases its risk of vertical root fracture in general, and that's why we're cusp covering a lot of these teeth. The other thing that happens is because the tooth is non-vital, the dentine's no longer supplied by pulpal fluid. We've got increased brittleness in the dentine. It's no longer hydrated. Think of it kind of like bark on a tree. You can see on the right. When the tree's quite dead, that bark is super brittle. So it's the exact same thing. And you've, by removing that kind of pericervical dentine, especially inside the pulp and root, you've got decreased ability for kind of adequate force absorption. Again, you're invading that biorim just from the inside. Perfect tooth essentially has a hard exterior and a softer interior. Enamel stronger, but brittle. Dentine's a little weaker, but has a cushioning effect. But, we want to figure out how to match this structure within a broken tooth. And we first need to deal with active disease. So There's, in terms of keeping the pulp alive, we want to work on our selective caries removal. This paper by Alleman and Magnier has done really well in conceptualizing that into very objective endpoints. All these acronyms on the side, again, more acronyms Biomimetic dentists created in the past, just so you guys know what you're reading if you read a random caption. Essentially, they grabbed a bunch of extracted molars, measured where the pulp was, and they've come up with these endpoints. 3 millimeters from the adjacent marginal ridge, 5 millimeters down from the cusp tip. That's where you kind of want to stop before you're probably going to hit the pulp. That will change depending on whether you're doing a large molar, a smaller molar, premolars, but it's just a general guideline. The peripheral seal zone is just 2 to 3 millimeters of completely clean tooth structure that we want peripherally. But how do we know what completely clean is? You can use tactile or visual methods, but it's quite subjective. How hard is too hard or how soft is too soft? So caries detector dye is a method, but we don't just want to blitz everything that's red. It's a more objective method. Look, what is it made of? I can discuss later. It's 1% acid red solution in a little kind of solvent, but that's not important. That's boring. What we need to do is figure out how to use it. So what essentially we want to do here, gain your initial access for the caries, clean the caries lesion as much as you can using water, air dry it pretty well, get a bit of caries detector dye, lather it all across your prep, and let it sit for 10 seconds so it's allowing itself to penetrate. You want to rinse that with water and dry. Then you remove the caries using those previous concepts, the peripheral seal zone, those caries endpoints, and then you repeat the process. And once you've got something that looks kind of like this, where peripherally we've got a clean substrate, but deeper, you've left some outer carious or inner carious dentine, that can help. And that can help preserve pulpal vitality while still getting a decent bond. But what is a decent bond? So surprisingly, this might be surprising to some of you, but the bond strength potential to different substrates is as follows. Superficial dentin, you can actually get bond strengths as high as 50 MPa, if not more. You can see below that, enamel is 30. Now, enamel is quite predictable to bond to, but the potential bond strength for dentine following specific protocols is higher, and that's well established in the research. Furthermore, you can see that the carious dentine is also reasonably high. Funnily enough, if you look at GI, essentially if I'm bonding to super carious dentine, I'm still getting a bond strength that's 2 to 3 times higher than most GIs. Now, the right protocols we'll talk about later, but just to summarize, where the right protocols will depend on reducing C-factor stresses, the kind of time we allow the dentine bond to mature, and a good prep. So again, we want to assess the tooth as to what cusp we're capping, how we design our prep, how we remove these cracks. This is a list of structural compromises the David and Davey Alleman came up with. They've already started to talk about dentine cracks. A couple of others, we've got isthmus width, the kind of width from buccal to lingual, buccal to palatal in your preps, or in your initial kind of filling that comes back to you that's failing or whatnot. There's some studies by Larson in the 80s where they could, intact bicuspids could withstand about 500 pounds of force. But after just a normal traditional preparation, if the 2 millimeter isthmus, it was bigger than 2 millimeters, they'd lose about 60% of their fracture resistance. In terms of cusp thickness, you can see that's another risk factor, less than 3 millimeters. Some papers in 2007 saying they're much more likely to fracture. Again, this will depend on your occlusion, if they're a bruxer or not, whether they're it's the buccal cusp and upper, those tension cusps, or lingual cusps for the lowers. Those are probably more likely to fracture. And the other one is the depth of your proximal box. Because much like a seesaw, if you've got a larger or deeper box, there's going to be an increased lever for things to flex. And we also know that down there, deep down, we're bonding to poorer quality dentine dentine with larger tubules, increased fluid. So bonding down there becomes a little even more trickier, right? So these are kind of assessments where they allow us to objectively look at a tooth and say, all right, this cusp needs some cusp capping. This area needs a bit more time for the dentine bond to mature. How do we maximize our bond in certain areas? Now, if we're looking at cracks, we've got a bunch of cracks, and we'll talk about all of them. Important thing here is cracks in enamel can actually be biomimetic. And the earlier we recognize these cracks, the better, right? Because we can potentially delay that restorative cycle of death. How do we visualize these cracks? Good magnification is really important, obviously. Good photos as well. Transillumination is one method. One thing that can help is air particle abrasion or dehydrating the teeth. You will see in some of the pictures later, just drying some areas of the teeth, you can immediately see the crack a lot more. You can also apply some primer on the area, and what it does is it changes the light refraction and helps in some cases if you're really doubtful. But occlusal reduction is key, especially if you know this tooth is going towards indirect or you're capping a cusp. As soon as you reduce those cusps, you can immediately see the cracks a lot better. It's one of the biggest issues I have with doing a core filling before prepping, because quite often that can hide cracks. Now, how do we treat these? Treating enamel cracks, as long as you find it early, the crack's not going into dentine, you remove the caries, you remove the crack, restore with direct, indirect, whatever you'd like. Indirect, you'd be looking at those other structural compromises. But essentially early risk assessment, early treatment, early success. Now, this is where it can get a little bit hairy, because these little cracks on the marginal ridges, that's what happens when you're removing those rainy ridges. Remember, we talked about removing those structures that connect the teeth side to side, front to back, top to bottom. And as a result, there's a lot more stress on the marginal ridge. And you can see those lines there. They're very easy to kind of sit and just watch. But that can be an issue. We already can see here, removing those rainy ridges in the middle, you're removing the spokes kind of like in a bike wheel. It's allowing that wheel to flex a lot more. What we also know is this phenomenon is called a peripheral rim fracture. You may or may not have had patients you've seen for a couple of years where their teeth are completely fine and suddenly there's a random class 2 lesion. You know they've been coming regularly. You know they've been seeing yourself or the hygienist regularly. You know they're cleaning well, they're flossing, gum health's decent. Why has this happened? It's because of this, right? We know that these cracks can eventually propagate to the dentine, especially in structural compromise. That study on the bottom right by Rikuchi, they've also shown that these infected cracks can open about 200 microns. We know the tooth's flexing a lot more, and bacteria go into this, and suddenly you have dentine caries. This phenomenon is called occlusal effect caries, again coined by Milicic and Rainey. And no judgment if you watch these. I have too in the past, right? But this is what's happening. Obviously, history taking is very important. Some key signs of cracks that are going unnoticed or cracks you can't even see, already coined by Brandstrom's famous papers in the 80s and a couple of others. But extreme sensitivity to cold, it could be due to opening and closing the cracks, could be due to like pulpal fluid movement. You've got sensitivity to sweets as well. It's not entirely kind of determined the exact mechanism there, but certain gradients and membrane movements and things. And of course, infection in the pulp, pain on biting, things like that. After all of your pulpal testing, it can help put together a bit of a story as to what's going on with this tooth. And dentine cracks are the real issue, right? We've got 3 main types of cracks. The oblique fractures you can see on the left, they're probably the most common. You kind of see them on a daily basis. What you're seeing there is the cracks going through the enamel. It's reaching the DJ and it's deflecting. And these kind of cracks, leaving them in the longer term, probably not going to result in pulpal death. What will eventually happen is one of those cusps or bits of tooth will fling off. The bigger issues are these vertical cracks that we see. They are tooth killers because they're going directly down, they're going into the nerve, and they're going down the root. Diagnosis often becomes difficult, and we know it's kind of driven by using vertical loads. It's driving adjacent cusps apart. It's what's happening in premolars. Premolars are the worst designed teeth in the world. It's why watching these, especially on premolars, are so deadly. And if you diagnose these early, you can save a lot of these teeth, but diagnosis is crucial. I've also got this effect on the right that can emerge from either one of these cracks, called the Poisson effect, where you've got this kind of spider web of cracks and fractures. You might have seen this when you've done an occlusal reduction before. And it's exacerbated by the compressive stresses of amalgam and wedging things apart. But these ones also are a bit hard to diagnose. They can go a little closer to the pulp as well. But just to know what you're looking at. And as long as we diagnose and treat these, we're going to have a bit of better luck. So just like those caries removal endpoints, the same measurements essentially apply for cracks. They're a little bit harder, and dissecting cracks are a little bit more difficult because we don't know how far is too far in terms of going deep. And they're also quite hard to simulate in a lab setting, right? You can see on the right here, we've got these, what they've done is they've found the cracks. They've done little pits and fissures here to maybe not fully remove the crack, but at least shorten the lever arm of the crack. A shorter crack's less likely to flex than a longer one. The tricky thing with this, the reason I don't personally do this, is what it does create is a really high C-factor environment. For those of you that don't remember, C-factors bonded to unbonded surfaces ratio, and the higher that C-factor, the bigger the stresses are on that bond, right? If we're relying on a bonded restoration, we want to reduce those stresses. So these can be a lot trickier. Probably do something a bit shallower that I'll show you in a bit. Now, in terms of dentine cracks, we've got those two types of cracks. We've got the oblique or horizontal cracks, which we want to fully remove. You can see that top picture there. As soon as I've done that occlusal reduction, and I've actually air abraded that area as well, you can see how that part of the tooth on the left is a lot lighter and drier than everything else. And it's drier because it's not connected to the tooth in that, the rest of the tooth and the pulp in that part anymore. So what I did for that is simply remove it. You chase it from the outside, so not the pulpal side, outside of that crack. You can use a burr, you can use air abrasion even, and point at that area, and you slowly will find that you remove that entire crack. Vertical cracks are a bit trickier because there are some people that just keep on chasing them down. There's some crazy people doing, restorations 4, 5, 6, 7, 8 millimeters subgingival. Sometimes it needs to be done, but if it doesn't really need to be, I don't see the need to put the patient and myself through that. So with vertical cracks, I try to fully remove them until I'm reaching the level of the rubber dam. Then I'm checking with my caries detector. Am I seeing that it's staining with my probe? Am I seeing that the crack feels really open, or is it quite smooth and not kind of, I can't really feel it anymore? And as it's going towards the pulp, I'm also making sure that diagnosis-wise, we've got everything okay. If I'm really doubtful about pulpal health, I might even temper it for a little bit, right? But these pictures help a lot, showing patients as well that, hey, your tooth's a bit more compromised. It's a bit cooked, right? So let's maybe watch this tooth a bit more, or maybe just be aware that there's going to be a bit of increased chance of needing a root canal in the future. What are your thoughts on that, right? One other thing these guys do with cracks that are entering that central stop zone inside the removal endpoints, closer to the pulp, is some people decide to place a fiber reinforcement, whether that's Ribond, Everex posterior, Everex flow. The fiber lengths are a bit different. I use it sometimes, not too much. It's not really essential. So I hope you guys have already realized this, but is the solution a crown? In most of these cases, probably not, right? We're automatically, with a circumferential gingival, like equigingival margin, we now are invading that biorim more than it needs to be. And removal of that pericervical dentine, it's going to increase tension. We know ceramic works poorly under tension, but really well in compression. With these axial walls of crown preps, we've got stress concentration areas. We've also got a more complicated prep with a high C factor. And we also know crowns remove a lot more tooth structure in general. You can see 70 versus like 47 or 32. So it's a lot smaller. The other issue is luted crowns, or traditionally cemented crowns. We know crowns in general, even like beautifully made lab crowns, they have a clinically acceptable margin of 50 microns. And that's because they assume that the cement's going to fill that area, right? But what do we want in that area? Because we all know that GI washes out over time. It's why no one does the open sandwich anymore. I hope you guys are not. And we can see on the bottom right that the bacterial cell is 1 micron. I'm sure you guys have all played Space Invaders, but where we've got all the invaders lined up, essentially like you've got 50 of them lined up, ready to go into your GI margin, right? Because there's no more GI there. There's just a 50 to, in some cases, 130 micron gap. So what do we want there instead? We want a bonded margin. And why do we want a bonded margin? It's because bonded margins bond in the nanometer range. It is smaller than that bacteria amount, right? And we know that resin doesn't wash out as long as we're following the protocols. So the solution here is we want to recreate the compression dome. So we want to recreate the natural tooth. That's what biomimetics is. Put it quite simply, ceramic replaces the enamel, resin replaces the dentine. It's actually quite simple when you look at it like that. Why? It's because of the mechanical properties, right? So you've got dentine and composite having pretty similar mechanical properties. So they're good replacements. Composite's a good shock absorber as well. And enamel actually matches up pretty well with feldspathic. The reason we've actually moved a little more towards lithium disilicate over the last a couple of decades is these teeth we're treating, they're a bit more compromised. We need a bit more of a reinforcement. We don't want something super brittle like zirconia or metal, but lithium disilicate seems to hit that sweet spot. What lithium disilicate though? There's quite a few on the market. Probably every week or every couple of weeks, you get a rep messaging you or rep in the clinic being like, my material is best. So far though, at least in my opinion, and us at BAD, Emax is still king. Fracture resistance is a big thing thrown around, but fatigue toughness is the key metric. Fatigue toughness is the material's ability to resist crack growth under cyclic loading, to withstand crack propagation before failure. Cyclic loading means repeated load. That kind of feels like someone that's chewing and using their teeth constantly, right? If you look at these values on the right, you can see that IPS Emax CAD is in that 2 range. Lisi, a competitor, is around the 1.5. Lisi Press is really good, but you're only getting that from a lab. And we've got Tessera, another popular one down here, which is around the 1.45. So a couple of different opinions there. The other materials still work. Even feldspathic works. It's definitely an alternative material I'll use, but Emax is my bread and butter. So where does the strength come from? We already know it comes from the bond with the right protocols. So the bond strength at the DEJ, or otherwise now known as the DEC, the complex, is approximately 50 MPa. That's how strongly enamel and dentine are joined together. Adhesive bonds, we know now, and we've known for a while, that we can achieve bond strengths that are more than that, especially in the dentine bond, right? You can see here that with these two, what we call gold standard adhesives, they're not gold standard because someone's just put a gold star on them. They're gold standard because they're the ones used in most of the research. We've got OptiBond FL and Clearfill SE bond. And you can see the dentine bond has almost twice the strength potential as the enamel bond. In terms of if you're really concerned about glass ceramic strength, bonded lithium disilicate, it's got 75% of the load-bearing capacity of 3Y zirconia, right? 3Y is the ugliest one. 4 and 5Y are a little bit nicer looking. They lose a little bit of strength. It's pretty equal to 4Y, but it's got not that zirconia can't be bonded, but lithium disilicate has a lot of long-term evidence for bonding. You can get covalent ionic bonds. Tends to be the best material to use. Now, we've covered the ceramic, replacing the enamel. What replaces the dentine? The resin, right? Again, another douchey term, the biobase. Essentially, it's a complex of that dentine and the resin that we're going to cover it with, right? It's a couple of concepts on the side that we'll cover in a second. And those all come together to form this biobase. What you can see on the right here is at the end, while I'm ready, that's my finalized prep, or my dentine is sealed. I've got a layer of flowable on top, got my enamel somewhat exposed, and that's my final prep, right? That's the biobase. Now, the dentine bond to receive or reach those bond strengths, it needs time. And you can see that in this paper by Liu in 2004, where 70% of that dentine bond development is in 1 minute, 90 in 5 minutes, and 95 in 30, right? This concept's called decoupling with time, and it's extremely useful, especially in high C factor areas, because we want more time for this dentine bond to develop with as little stress as possible. And that's because this hybrid layer, the dentine bond is really strong, but because of that maturity that it needs to be separated from the enamel. It needs to have less stress in terms of C factor and polymerization shrinkage as well. What that polymerization shrinkage is essentially the shrinkage of your composite. The bigger your composite increment, the larger they are, the quicker they're put on, the more that composite is shrinking. And that starts to play into the way we seal this dentine. And what about if you're kind of replacing or bonding in your final restoration after a couple of weeks? Let's say you put a temp on, you're coming back to it. We can see there's no reduction in the bond strength up to 12 weeks later. They just didn't check past 12 weeks, so we don't know if it's more than 12 weeks is okay. But you can actually see that with OptiBond FL, the thicker bond, it's got a thicker film thickness. At 7 weeks, it was actually statistically significantly higher than the ones before. You can also see the delayed dentine sealing group. Essentially what that is, let's say you've done your prep, you don't do anything to the dentine, you've just got your dentine exposed, you make your ceramic, you come at insert, and then you put your bonding agent on the dentine and insert everything in. Kind of your standard bonding. You can see the bond strengths there and how low they are in comparison to some of these numbers here, right? Especially with SE bond, it's like 2. It's because the film thickness is quite low. And we haven't allowed that time for the dentine bond to develop. We've just put a massive ceramic on it. And how do we make this all come together? We're going to talk about some prep design stuff in a second, but I want to talk about the actual steps for bonding here. So immediate dentine sealing. It's what we've been talking about for a little while. We want to seal the dentine with resin immediately after the tooth has been prepared. You'll be using air abrasion depending on the bonding system. Like I said, you've got 2 gold standards. You've got the OptiBond FL, which has a thicker film thickness. It's just thicker. It's almost like a thin flowable. And you've got Clearfill SE Bond, which is a 6th-gen self-etch system. It's a bit thinner, right? You've also got this thing called the resin coat, which is a 0.5 millimeter flowable layer placed on top. Essentially, to allow that dentine bond to have some time to mature, this is what allows it to do so. You do all these steps at the prep appointment before you take your final scan. So then between prep and insert, whether that's a 30, 60-minute CEREC milling, whatever, or whether that's your lab making it over 2 to 3 weeks, you've got some time for that dentine bond to mature. And what that allows for is it to mature in a very low C factor environment with little polymerization stress and to achieve those crazy high bond strengths. In terms of sealing the dentine, there's kind of differences in the people that discovered this concept. The Japanese were, back in the day, used to seal the dentine as well as the enamel. So they used to just seal everything with especially their flowable. The Europeans and the Americans as well, they started just sealing the dentine and they went back and re-exposed their enamel. Doesn't really matter which way you go. These days, we like to focus more on refreshing the enamel. So we've got that predictable enamel bond as well. But I would always err on the side of making sure all of my dentine is covered because we want to maximize that dentine bond. So if I go over the enamel a little bit, it's not the end of the world. And this is that resin coating. There's a couple of studies up the top here that you can read later, but it's that 0.5 millimeters of flowable. Why is that important? Because, and if you read some of the studies that show that, or that try to show that, IDS doesn't work that well, you have to just look in the steps or what steps they take. If you put a really thin bonding agent like Clearfill SE over the dentine, you've got issues with the oxygen inhibition layer. We know that the top layer of resin is inhibited by the oxygen about 10 to 40 microns. If you've got adhesives that are 5 microns thick, is any of it really curing? Probably not. You've also got pulpal transitation and fluid coming up from the pulp. A little less so if you air particle abrade, but you've got fluid coming from the bottom. You've got uncured resin from the top. By the time you come back to insert, do you even have resin there? Probably not, right? So applying that resin coat, especially for thinner adhesives like SE bond, it allows that thickness of resin to be a lot thicker without putting too much stress on the hybrid layer, because it's still a very thin layer. It supplies that kind of a IDS layer with additional monomers, allows even more time for it to mature. Let's say you're doing a direct restoration. Applying that flowable layer still takes a little bit of time, allows you a bit more time. You don't have to wait and sit there for your 5 minutes as it decouples with time. You can just start building a wall, like a class 2 box, or work on another tooth, or, there's plenty of things you can be doing. And the other thing this resin coat helps with is that when you air particle abrade an insert, when you're air particle abrading the tooth, it stops that re-exposure of dentine because the layer over the dentine is now thicker. I know I'm talking about these particular adhesives. The one on the right is actually not available in Australia, but it's even better than SE bond. But this resin coating layer will improve almost any adhesive. These bottles are much better than a universal adhesive, much like normal shampoo is much better than 5-in-1 shampoo, conditioner, and etc. Right? Because universal adhesives just have way too many things in them. But resin coating will still improve and reinforce a lot of those extremely thin universal adhesives as well. The key thing between OptiBond FL and SE Bond's quite thin and it's self-etch. So when I'm IDSing for that, all I'm doing is air particle abrading, applying my dentine bond over the dentine, and I'm not etching when I'm doing my IDS layer, because the self-etch in SE Bond 2 is going to mildly etch the dentine to an appropriate layer. With OptiBond FL, though, it's a total etch fourth gen system, so I'd be total etching everything for 15 seconds. So in that way, they differ a little bit. OptiBond FL, because it's quite thick, it can be up to 80 microns, especially if you put a couple of layers on. In some cases, you don't need the resin coating layer. I use SE Bond mostly, but I'll use OptiBond FL when I'm redoing a crown prep, because I've got these tall axial walls. I still want to incorporate some of these factors, but I can't turn a crown prep into an overlay prep because the crown's already been prepped, years ago. So what I can do though is incorporate some of these concepts and still seal the dentine. It's far easier to do it with a thinner OptiBond than to try drag flowable all across. Now, what do you do when the biorem's already lost, right? In some cases, yes, you can take your ceramic all the way down there, but deep margin elevation is essentially just an extension of the immediate dentine seal. It's essentially applying resin in that deep area to raise the margin and have your ceramic sitting on top. And the key things here is you need gold standard isolation. You need full rubber dam isolation. But there's a whole host of benefits. Again, you're allowing that deeper, hard to bond dentine a lot more time to mature. You've got easier isolation at insert. You can see that bottom picture is at insert there, so it's a lot easier. You can protect cervical tooth structure and even enamel, brittle enamel. I like to cover that with flowable as well, and allows some stress relief, right? You can see with the Gerges matrix in this image on the side, we've also increased the bondable surface. You can see that bottom picture is a lot wider than that top one, which means more of that tooth is going to be in compression, which is exactly what we want. Success rates are pretty good for deep margin elevation, as long as they're done right. Now, in a GDR lecture, I obviously have to talk about perio because of Dr. Alex Kaminsky, right? And there's been some kind of controversy in terms of, does deep margin elevation, is it well tolerated by the periodontium? And the study on the left actually says no. You don't get much bone loss, but you get a bit of BOP. But when you look closer at that study and you look at the patient population and the selection, it's quite random. There's a bunch of smokers in there. There's no control on hygiene. There's no control for other comorbidities. A bunch of different things. Study on the right by Bertoldi. They kind of tried to fix some of those things, and they controlled a little more for putting some hygiene protocols in, selecting for patients that don't have huge conflicting comorbidities and non-smokers. And there they found that the periodontium next to these deep margin elevated resins was very similar to adjacent untreated roots. There's a bunch of other papers by Didier Dici, Roberto Spriafico, Magnier, as a German group in 2014, I think. There's a whole host of stuff, right? So you can just read for days. Another critique is deep margin elevation. Some people say, oh, there's multiple margins, right? One thing I'd probably ask you is when you place your direct fillings, is there a margin between each increment? No, there isn't, right? And in this same way, you've got your deep margin elevation layer and you've got your final resin cement or your flowable. That's all bonded together because we're dealing with bonded margins. So it's essentially like if you took your resin cement layer and you just made it thicker. That's literally it. The key thing with deep margin elevation is because we're dealing with really deep, hard to bond to tooth structure, we want that good isolation, and we want to be placing very small increments, 0.5 to 1 millimeters at a time to allow that bond to mature rather than bulk filling, because it increases the bond strengths quite a bit. Now, how do we improve our preps? Because I keep talking about C factor and all that fun stuff, but we can control our C factor with good preps as well, right? So these are some important things to consider. Got some CEREC stuff in here as well, but I'll skip through it. Occlusal clearance, that's priority number one. You need that occlusal clearance for your material of choice. With EMAX, their occlusal clearance requirements are 1 millimeter. The more you give, the better. We already know that with a lot of the teeth we're treating, a lot of the cooked teeth, the rainy ridges are gone, right? Those subocclusal transverse enamel ridges, they're gone because we've got amalgams and cracks and all that fun stuff. We know the cusp tips don't matter too much. So yes, you can try, do some fancy partial coverage stuff. Yes, it is better in some areas, but especially when you're starting out, that is the least critical area of the tooth because we've already lost that stuff. So err on the side of going a little bit more as long as you're not getting too close to the pulp. Ways to do that, use a predetermined burr thickness, or you can use a Meisinger type depth cutting burr. Just develop a system and it'll be a lot easier. Now, margins. I think I said this 100 times on the weekend. We were teaching about 45 to 50 dentists at BAD Melbourne, but we want smooth internal line angles because ceramic doesn't like and resin doesn't like sharp angles, but we want very sharp external line angles. And what do I mean by that? We want sharp margins, right? And that's because it's going to be identified a lot better by your scanner or your impression material and by your CEREC or by your lab. So you can put bevels in there. Steeper bevels do help. Bevels are quite nice for not only blending in things, but above that height of contour, above the biorim, beveling the enamel can actually increase the bondable area for the enamel there. Generally, rule of thumb, above the height of contour, I'm beveling. Below the height of contour, I'm doing a butt joint. It's pretty similar. No chamfers or anything like that. How do we get this sharp external line angle? Football burrs, discs, even just holding a straight burr along the side and going across at the end works really well. Now, we want nice broad contact points and we want very smooth internal line angles for this reason. When your lab is milling out your ceramic, if there's sharp areas there, especially if they're getting into minimal thickness issues, what that burr is going to do, not your burr, but the ceramic milling machine burr, is it's going to over mill in that area. So then your ceramic still fits. That now becomes a stress concentration and also becomes a thickness issue as well, right? So just make sure you're getting adequate thickness and internally everything's nice and smooth. You can also polish up your adjacent contacts, make them nice and broad, use a disc or a burr for that. In terms of finishing and smoothness, it reduces the risks of those kind of final things. You can see we've done a deep margin elevation here and we've re-exposed some of the enamel here, but there's no real dentine exposed, right? It's going to reduce those internal stresses, increase fracture resistance of the ceramic. You can use slow speed polishers, discs, again, red band handpiece, footballs, flames, whatever you'd like, right? Just figure out one thing and be efficient with it. Gingival management's a huge one. You can either retract or you can remove the gingiva, or you can do both, right? You'll see in a couple of cases later, I'm pretty aggressive with removing the gingiva, and you'll see why. But the reason we need this is we need a good bonding area, but we also need a good area, isolated area to scan. And in terms of retraction, you can use things like Teflon, retraction cord, even rubber dam provides some level of retraction. You can see here at the top, I've got a Brinker's clamp. It's an accessory retraction clamp. And at the bottom, I've got what's called a floss ligature, which is also pulling the rubber dam down a little bit more. In terms of removal, you can use a thermocut burr, you can use laser, electrosurgery. I've got these tungsten carbide finishing burrs in all of my burr kits. I just turn the water off and blitz the gum away. Before rubber dam goes on, I make sure that most margins are supragingival. When I say supragingival, they were probably sub before, but I've gingivectomied or I've put some kind of retraction there to make them supragingival. The thermocut burrs are quite cheap. The other thing that might work is when you send your handpieces off for repair, sometimes they come back with this random, like, useless burr in them. That one's, weirdly enough, quite good for removing gingiva as well. Just no water, so you get a cauterizing effect as you go through. In terms of scanning as well, won't spend too much time on this, but definitely be methodical with your scans. I've got some studies by Jadol down here that say that you can actually do your pre-op scans, especially with 1 or 2 teeth. If you're treating them, you're not changing the bite. You're conforming to the existing bite. So you can even take a bite scan there. And then after you've put your rubber dam on, you've done your entire prep, you can just cut out the prepped tooth, make sure you've got a couple of other teeth either side on the rubber dam, and then scan again, and it'll stitch everything together. You'll see an example of that later. And you can see there's very specific scanning patterns. Whatever your scanner is, just figure that out for that scanner. Just Google it, ask the rep. For kind of quadrants, I generally only half arch scan. It depends on what kind of scans you're doing. I'm going to skip through some of this CEREC stuff. Block selection's a big one because everyone on Instagram wants that blend, right? Generally, high translucency blocks with Emax work quite well. Especially because we're only dealing with the incisal, occlusal to middle third. Generally, you want to match the shade with that incisal portion and then stain and glaze accordingly. Bevels help, but don't make them steeper than 30 to 45 degrees. And using a warm cement, or what I like to use is either heated composite or heated flowable, that works so well to get these blends. You'd use low translucencies if you're replacing existing crown, you've got discoloration, but at the back of the mouth, these things matter a lot less, right? Now, cementation steps. These ones will vary depending on what materials and things you have, but I'll give you a quick rundown. Essentially, you'll try your ceramic in, and now you need to clear kind of saliva, blood contamination. I essentially just wash it, and I go straight on to ceramic etching. I don't really do an IVA-clean step before. Ceramic etching takes care of it. Depending on the concentration of your ceramic etch, make sure you're etching for the right time. 5% is 20 seconds. The 9.5 to 10%, it is buffered, so it is not less time. If you do it for less time, your ceramics are going to pop off. You guys are going to complain. It's going to be 60 seconds because it's a buffered solution. And then what I like to do is go over the margins a little bit as well, and then you wash and dry that off. You want to clean these ceramic salts that develop on the actual ceramic. So the way you do that, research says you can use phosphoric acid etch. You can use cleaning pastes like IVA-clean. They remove most of the salts, but not quite all of them. So you want to use something like an ultrasonic bath, like this one here by BAD, but you can use distilled water in this one. Some baths let you use alcohol as well. What that's doing is removing all of these excess salts that have been created from the etching process and allowing for a better, cleaner, bondable surface. While this ultrasonic bath's going on, it takes about a minute or two, it's got a timer. That's when I'm putting my rubber dam on to get ready for the tooth preparation stuff. Once it comes out of the bath, dry it really well, put a ceramic primer on. These are two I've used routinely, Monobond Plus and Clearfill Ceramic Primer Plus. Do not use Monobond Etch and Prime. We're talking about Monobond Plus here. You apply that for 60 seconds. You want to air dry it a little bit. Sometimes heat drying it works well. What I actually do is I chuck it straight into my ceramic heater, which is here. I also heat my cement that I'm going to use, which is generally flowable or packable. I don't really use resin cements much, but they're a good place to start. Flowable or packable generally have better fracture resistance or fracture toughness. And they are also fully light cured. So I've got all the time in the world to clean up things, right? Got a bunch of other benefits there, but heating the ceramic, what that does is it retains heat in the ceramic. And it means that especially if I'm using packable composite, I dispense the packable composite straight into that ceramic. Composite's a poor conductor of heat. So I know if I touch it with a cold instrument, it's going to lose heat. I'm going to be stressed at insert. But if it's being held in by a heated ceramic, ceramic's a very good conductor of heat, it's going to retain that heat for a lot longer. But heated flowable is a good middle ground. It's a bit better than resin cement, but they're all quite good. Now, in terms of the tooth prep, patients come back. If they've got a temp off, I'm removing that. If it's a CEREC, I haven't put a temp on. And I'm air particle abrading. It's doing a couple of things. But one thing it's doing for this step here is it's cleaning the surface, but it's also increasing the micromechanical kind of surface area for bonding. You're essentially doubling that surface area, which allows for a final diffusion reaction of all the resins and everything together. If you really want to be extra, you can use this material called Cojet, but it's not really needed. This is just 50 micron aluminium oxide. If you don't have an air abrasion unit, get one. It's a very cheap one by Amalgadent. It's called Danville Micro Etcher 2A, I think. This Rondo Flex is the one that I use. It's honestly really good. Comes with water as well, so it keeps things a bit cleaner. If you really don't have one, you can use a yellow band football, but it's just a bit iffy. Second step, we're total etching for 30 seconds, mainly because there's no dentine exposed anymore. I'm not worried about over etching dentine or anything. So I'm just etching enamel and composite. We're washing and drying that. And then we're putting our final adhesive, whether that's OptiBond or SE Bond. I'm putting that on and I'm not curing that because we're not worried about dentine stresses anymore. It's all covered. Enamel bond's quite predictable. You can pretty much use anything here. I'll put some primer on if I'm worried about dentine exposure. In fact, if I'm really worried, I can see a spot. What I'll do is I'll use a thinner bond like SE Bond, put a bit of primer there after air abrading, put a little bit of bond, just a tiny bit, make sure there's no pooling, cure that, and then I'll go ahead with my initial bonding steps. So at least there's a bit more time and I'm not interfering with the seat. And the next steps here are the insert process, right? What I'm essentially doing, picking up my ceramic from the heater, squashing it onto the tooth, which now has rubber dam on it. I'm cleaning up as much excess as I can. And then I'm actually tack curing it. Composites actually tack cure pretty well, much like resin cements and other cements. But I'm tack curing it. You can see down here, I've got a bit of Teflon around the sides as well, just to stop composite from going down. I do that if I'm feeling a little extra, but a lot of the times, a bit of Gorilla Floss with some knots in it. I'll tack cure the ceramic, get my assistant to hold things down, floss through, and just drag my Gorilla Floss with knots back and forth. After that, again, we want to get rid of the oxygen inhibition layer right at that margin, so we've got a truly seamless surface. You can see in that video that I played there that just a little bit of that composite has popped out, right? I actually don't mind if that stays there because I can always polish it back. It's composite. It's a material I'm familiar with. I can always polish it later. I'll actually tack cure that, make sure it's kind of a little polymerized, and put glycerin all over the entire thing. That's KY jelly or any other kind of clear liquid. Even ultrasound gel works really well. Cover the whole thing and cure through it. Because it's using composite is fully light cured, you want to make sure you're curing quite a bit. I generally do like 40, 60 seconds a surface, even more if I'm doubtful if I've got a thicker composite. This is just some dental codes you can use. If you're going partial coverage where you're keeping a cusp, you might opt to use some of these codes. You can use the gingivectomy code if you really want, if it's something that's taking you a bit longer, and will depend highly on kind of what practice you're at and if they're preferred provider or not. Got a bunch of alternative materials. I won't spend too much time on this. We've got some hybrid ceramics and composite blocks that are still good in terms of cost effectiveness. Telio is good for temps, but don't really use this one much. And some of your feldspathics work really well, especially if you've got a CEREC, because sometimes you have these blocks lying around, you've got an emergency appointment, you don't have time to fire stuff. And what I mean by fire is put it in a furnace. So these ones mill and you can bond them straight in. And a lot of long-term research for these as well. This is what, if I'm sending to a lab, this is kind of what my lab prescription looks like. Mostly focused on occlusion because we want a lot of that compression. So even though nice inclined cusps look really, they look beautiful, they're not really conducive to what we're going for with these, cracked teeth, right? So I'll be including a lot of things to make those a little bit shallower. I want shallow cuspal angles. I don't mind this increased micron spacer because, again, we've got bonded margins, right? I'm erring on the higher side of this if I know I'm going to bond in with heated packable composite because I want a little bit more give there. One note I didn't say before is if you're going to use a heated packable composite, you want to use a microhybrid composite, something like Clearfill APX or Z250, I think that's Filtech, because some of the other ones, some of the non-microhybrid types, they have thicker kind of components in them where it actually doesn't let the composite squash to thin enough of a layer. So Clearfill APX is a good long-term one. Be careful heating it for too long, it can set. That's why if you're starting out, definitely use a resin cement or a heated flowable. It's a good middle ground, and then move on to heated packable when you want some more fun. The bottom of that prescription, make sure they're not ceramic etching or silinating that ceramic. The only exception here is if you've got an in-house lab, you're lucky enough to have one of those, and they're giving you the ceramic straight away. A couple of notes on case acceptance before we go through some cases. Patient communication is key, right? You guys taking time out of your day or your evening to kind of watch this lecture. Over-treatment's a huge issue, but so is under-treatment. Show them pictures like this, and they will realize the issues that are going on, right? And it's also a good diagnostic tool for yourself. Photography and scans are quite a big thing. This is an emergency patient that came in. They're like, oh yeah, look, I think my tooth's a bit broken. It's clearly been broken for a little longer. There's literal gingiva growing into that tooth. I took one picture there and the patient's like, yeah, all right. I can see we need to do something here. And you can change the discussion from, why do I need to fix that to how do I fix that as soon as possible? Especially for a fresh new grad where communication skills, they can only get better, let's be honest. Pictures tell so much and they stop you from speaking, which sometimes is a good thing, especially for me. So clear photos are really important. Get a camera, DSLR, even intraoral cameras are good. Intraoral scans as well. You want to leverage the technology that you've got, right? You'd be surprised. Every clinic has a lot of clinics have scanners, but you show a patient, you actually bother to show a patient a scanner and they're like, oh my God, this is the coolest technology, even though you definitely know their previous dentist had a scanner. And why do I need this type of dentistry, or why do I need this? This is a patient that came in who actually was non-English speaking, couldn't speak any English, but she came in with her son so then he could translate. The first word she said was, oh, when she saw this picture. And just like I said before, these pictures give you so much information and they convey so much information that you sometimes don't even have to speak, right? They've got a couple of analogies on the side that help relate it in non-dental terms to a patient. And you can also stand apart from the crowd a little bit when you're doing biomimetics, right? We are doing adhesive dentistry, but we're doing it in specific ways to conserve tooth structure as much as possible for the benefit of us, of course. We don't want complications, but primarily for the benefit of the patient, right? Because if this fails, I can always come back. The likely failure mode is going to be between the ceramic and the tooth, not of the tooth itself. See on the top here, we've got a decoronated tooth with a traditional crown. The amount of time someone's come back and said with that crown in their hand, with the tooth and the core inside it, saying, hey, can you stick this back on? At that point, you have to have a bit of a discussion of, we really can't, right? It doesn't matter that the crown is still intact. The tooth's cooked, so we can't really do anything about it. Don't put other dentists down, but definitely leverage the skills that you have and talk to them about it. Consent's very important as well. And consent involves telling them what's going to happen if they don't get treatment, right? Even though these look like enoki mushrooms, they're actually GP points from an extracted tooth that didn't have cuspal coverage after root canal. So you want to be educating them of the biological consequences, but also the financial, right? So this patient now has had an extraction, they opted for a socket graft, and they're going to get an implant. And those costs add up a lot more than simply a ceramic after a root canal. So in terms of when they ask, how long do I have? It's quite difficult to give that, right? So the analogy I use a lot is kind of cutting a tree down, where each hit of the axe doesn't really do much, but at the very end, that whole tree comes toppling down. It's always a sandwich or like the softest food in the world that makes that tooth finally crack in half, right? As it sounds harsh, but I needed to hear as well. Just be a bit normal, right? You'll develop your own way of talking to the patient after a while. You don't use these cookie cutter programs that are out there. There's a couple that I won't name, but you will eventually develop your own method, but use some of these things that I mentioned to leverage your kind of technology and your photos and your skills before you've got the skills to actually communicate them yourself. And body language is very important. Not every patient is going to accept your treatment. Your job at the end of the day is show them that, educate them. If they don't want it, they don't want it. Big deal, right? They're going to come back with an extracted tooth. It's sad, but it is what it is. All right, so just to end off, we're going to go through some cases, and a lot of these cases are actually very early on when I first started doing these, and it's because even these photos helped me a lot in identifying common areas or common things that I miss while prepping, like things to look out for and things that you can use your photos to do so as well. There's a couple at the end that are a bit newer, but the first few are quite old. The key thing I want you guys to remember is that we've got an old retentive prep we're replacing here. We've got a new, we've got our non-retentive prep at the end, right? I'm quite lazy as a person. The reason this kind of dentistry attracted me is obviously all the biological stuff, and cracks and good bond strengths, but I'm super lazy. Doing a prep like this is essentially doing the occlusal reduction and then just stopping halfway, right? It becomes a lot simpler, and they're quick preps that you can do. When you're replacing crowns, though, that's when things become a little more difficult. So there's my head there. We've got a margin. A sad face, right? What I want all of you guys to channel, just like Bill Gerges before and a couple of the other boys that I teach with, what I want you to channel is this compression dome, right? We want a nice, smooth, low C factor prep. And I want you to channel this every single time you guys prep a tooth for an overlay. That's that same tooth. I will honestly credit the dentist that did this a long time ago. Given it's a more conservative gold kind of almost overlay, there's enamel on either sides. There's a massive gap on the distal shore, but enamel on either sides, the margins were a bit higher, but we've still got that traditional core. It's probably luted on as well because it was quite easy to remove. And you can see what's going on under there, right? That's because, remember that Space Invader thing with 50 bacterium lined up, ready to go in? That's what's happening here, right? I don't even know what that is. It made me, question my job as a dentist, but there's not much to work with there until you remove everything. The good thing is the pulp was still vital there. So credits to that other dentist for at least being, conservative with that, because it gave us another chance. It's what this type of dentistry is about. Remove the cracks, remove the old restorations. You can see the tinge of red in there from the caries detector dye, some of the kind of central area that I've kept in there without removing fully. Sealed the dentine, and we've got our ceramic on. People. Same thing here. We've got compromised teeth. Remember those Alaman structural compromises? We've got really thin cusps here. We've got some marginal breakdown here. We've got a bunch of cracks and things as well. And we know those amalgams are divergent underneath, right? So we know those cusps are even thinner below. But we've got a huge, safe bioroom there that hasn't been invaded except for in these areas here. So why not do an overlay prep? And we're doing a filling at the same time, but prep these for overlays, seal the dentine. You can see with this view here, I show this one to patients a lot because even they can easily see all of that healthy tooth that we've got down there while dealing with the issues that we've got up here. These buccal amalgams, just a little tip, they're a bit hit or miss for me. Sometimes I will, if they're a bit lower down, I'll restore them separately. If they're up here and I notice that this wall is getting super thin, there's a crack there or there's caries there, that's where I'm dropping the entire thing. In this case, by the time I was done my occlusal reduction, I was pretty much there, right? One thing you'll notice though is if you've got amalgams that are like this, and you do half of your occlusal reduction and you do your occlusal reduction and you're there, you still got the amalgam down here. You've got an undercut. Undercuts don't work well because the ceramic's not going to be able to fit. You've got two options. You can either remove the rest of that and remove a lot more tooth structure, or what you can do in your IDS and resin coat layer is simply remove that amalgam and just seal that area up with composite to fill in those undercuts. In that way, you can be even more conservative, stay further away from the pulp, but still have enough occlusal reduction for your ceramic. More people. And those are those same ceramics. You can see that kind of biorim there. And we did these with heated composite. So nice margins there. Same issue here. We're dealing with these two teeth. One thing you can't see there is she actually had an open sandwich restoration here, a bit of GI extending all across the back, but in actual fact, she had a pretty large gap. Some of the GI had washed out. There's caries down there. So after you've prepped these, suddenly you've got a deep margin situation. We've got this area here that was about maybe 3 millimeters sub G, done a gingivectomy there, put the rubber dam on, put this over. This is the Gurkus Matrix, the V1 version. This photo was really important for me because, again, this was quite early on. And you can see what I didn't do here was that exact shape of the matrix is what we've got here. And you can see there's a little bit of a discrepancy here. And I didn't notice that initially. What I should have done is after taking the matrix off before scanning, just polish things up a little bit. The good thing about resin is you can polish things later, right? So I cemented the final ceramics on and I just polished that area later. Wasn't that big of a deal. And heated composite here. And those are the final ceramics over there. That's Pitbull having a surf and a ski. Now this one here, it's an old crown that's popped off. Not an old crown. This was only 2 months old, I think. And crown popped off. I think she'd swallowed it. Probably weren't going to rebond that one on anyway, because you can see we've got some like retentive slots or something going on there and some sharp areas here. So even though it looks like it's quite flat here, it's because the view is from a little further up. All I really did here was round off these sharp angles a bit more, remove any other caries that was there because there was still caries that stained with caries detector dye, and then filled in this entire area with resin. So that way I didn't have to remove everything. I didn't have to worry about path of insertion issues. I didn't have to worry about sharp internal angles. Everything smooths over with the resin. The other good thing about the IDS and resin coat layer is you can spend hours smoothing your preps, but a little layer of resin does the exact same thing, especially at self levels. I use Clearfill Majesty Flow or Clearfill Majesty ES Flow. And it's self-leveling, which just means when I apply it, kind of settles down and gets into all those nooks, crannies, undercuts, and preps are quite smooth and they look quite frosty as well. Now, these are going to be your bread and butter preps. These are ones with maybe marginal cracks or little occlusal amalgams. These preps take no time at all. You can do these preps genuinely just an occlusal reduction, prep the proximals, chuck on a rubber dam and do your IDS and you're done, right? It's like 15, 20 minutes, maybe a little bit longer. As you do them more and more, you'll start to get quicker and quicker at these. Don't worry if you're not at those times with these guys at the start. You will be, I promise you. And same thing here, just more preps. This one was weird. I think I used the floss tie as a clamp and put the clamp somewhere else. I should have just put a clamp on that tooth. That was quite dumb of me. And you'll see teeth like this quite often where we've got breakdown up top and we've got kind of a gingival recession as well. And this patient wasn't sensitive, but sometimes they are, right? So if there's no caries there, but they're sensitive or they're worried about exposure or whatnot, one thing you can do is extend the margin all the way down there, but it's quite a lot of tooth structure to remove. I'll extend the margin down there sometimes for premolars because they're a bit more aesthetic, and I'll veneer that margin. But for molars, especially if they're sensitive or they're trapping plaque, I'll cover it with a little bit of additional flowable after removing any plaque, or packable composite, and just do a separate class 5, right? That way you don't have to prep as much. It still blends in quite well. It's a good all-round solution. OptiBond FL works pretty well there as well because it's a bit thicker. As long as you get good isolation, total etch, OptiBond Prime, OptiBond FL, maybe a little bit of flowable over the top. It's quite quick to do as well, and it solves a lot of issues. Also get them on Sensodyne before you even do that, because it might reduce their sensitivity quite a bit. Some other preps here. Again, the same principles, right? We're exposing that enamel at the end, but we've got our dentine secured. I could have kept these cusps, but I didn't because this patient's a bruxer. There is some more recent evidence to show that if you're capping cusps that are thicker than 3 millimeters, there is a bit more chance of catastrophic failure, which means failure further down the tooth. But again, this is still significantly less than doing a traditional crown prep. You're still significantly more conservative. And you also have to deal with the practical consequences of cusps flinging off, a year or two in if something changes and the patient being like, bruh. So, maybe balance those things and see how you go. These were 2 teeth I treated in 2023. It was a 1.6 and a 2.6 here. I think the 2.6 is first. So in the same steps, we've done our occlusal reduction, prepped out the proximals, removed most of the restorative material. That 2.7 needs some love, but sealed the dentine, and we've got our final ceramic, right? Got a nice bevel above the height of contour there. You can see things blend in pretty well. On the other side, you might remember on this bite wing, we've got a very deep filling there. It's clearly subgingival as well. It's going to extend a bit more, getting quite close to the nerve as well, but things were vital and acting normal. And what I did here is I margin elevated here. The emergence didn't matter as much. So all I did here was I had a wider clamp. I opened the clamp, shoved the sectional in, closed the clamp, and then margin elevated. I also had plenty of room to polish back if I really needed to. Try to avoid polishing those deep margins because polishing them with a burr or finishing strip can actually make them a little rougher than just a nice smooth matrix. But especially in a cleansable area back there where she's got no tooth behind, I had no issue. Here, I didn't just use small layers of flowable. I used a layer of packable as well. And then you can see the final ceramic there blends in pretty well. And these are bite wings I took of that same case in 2025. And you can see in April, so what is that, a month and a half ago, where we did these guys at the bottom. But that one's still looking nice and stable. Pulp's still vital and normal. She just forgot we did it. And this guy's looking pretty good as well. We got to get on this guy. She's finally agreed to do so. That pulp is so dead. So we're going to have to do root canal on that tooth. Now, more preps here. These are a bit more recent. And there's one critique of this prep, and it's the fact that the enamel isn't kind of re-exposed in this area, right? You can see how thick our enamel is here. And we don't quite have that enamel exposure everywhere here, right? We've just got our thin layers. I'm not super concerned by this because I used OptiBond FL followed by a resin coat for this layer, for the IDS here. And remember, OptiBond FL is a total etch system. So I'm actually etching before my IDS, whereas with Clearfill SE, I'm only air abrading. I'm not actually etching before my IDS layer. So because I've etched the enamel there as well, I've got a good bond with the resin. I'm not really super concerned by that. I feel like that one's going to be fine. What I was talking about before with gingivectomies, you can see I'm pretty brazen with gingivectomies because I did it once. I got scared. They came back 2 weeks later for the review and they were actually still alive. So I just kept doing it, just like all of my colleagues, and they still lived. So this was actually a crown redo case. Again, made me hate my life on that day. But also gave me a bit of reassurance with the bond, right? Because this was a case that wasn't I'm not sure where it was done, who did it, but it was, there was no dentine sealing or anything from what I could tell. Traditional type prep, but it was bonded on with Emax, right? And prepping that off is essentially just prepping a tooth because it's so well bonded on. The issue we had though is we had distal caries, recurrent caries between here and here. And we had distal caries on the 7, probably because of the super erupted 7 as well, which it'll make more sense in a sec. We, just like any other prep, the principles are the exact same. Tooth still vital, caries removal endpoints, get rubber dam on, get some isolation. We've got a Brinker's clamp there, a B4 clamp. Got a bit of some flowable tags here as well, just to retain that clamp a bit more. And I kept it relatively stable, restored this directly, and then that's the final ceramic on. These are the bite wings here. You can see that recurrent decay before. Gonna have a chat to her about, it's a non-functional tooth. Do we cut our losses with this guy? But we'll see how she's going in terms of cleaning. Get another one, which is super bread and butter. We've got these marginal ridge cracks. We had some symptoms with these guys here as well. Done our occlusal reduction. One big issue I have with core restorations is quite often people will remove this amalgam, place a composite, or maybe even use this amalgam as the core. It depends on what your philosophy is. And then prep around it, right? The issue with that is if you go to this slide here, but especially the next slide where I've aerabrated and I can see that crack. If you hadn't done your occlusal reduction, removed your amalgam, had a look at the tooth before then IDSing it, you would not see that crack. And what would happen is that patient would probably come back with more symptoms, right? Especially as with a traditional crown prep, you're removing the bioroom, you've got to increase flexure, all those things we talked about before. But with this method, you can critically evaluate and remove these cracks. It's a horizontal or oblique crack. So remove that completely. I used SE Bond and my Clearfill Majesty Flow for this. So, and then IDS'd and ready to kind of insert, right? And much the same, just more preps, the exact same philosophies. You can see some of these photos tell me, I got to this spot, but I took this photo and then I could see here I had a bit of resin left over, right? So these photos give a lot of information, even to me during the preps, because sometimes I miss things. Another case, we had a very nervous patient. His tooth was really starting to bother her. Looks okay at the start, just like a huge composite, but it was quite deep. We did a full lingual deep margin elevation. Again, we're bonding to a lot of poor quality dentine. So we want to allow that additional time, right? We've also got a bit of a higher C factor area here because of the pins that we removed. That's what those holes are. And sealing all of that as well was very important in gradual layers. It could even argue to put some fiber reinforced composite or rib-bond over that area if you really wanted to. And things sealed up, and the final ceramic. More ceramics here. Again, more information from my photos, right? You've got some composite remaining here. Even though I've got my matrix on, I took that photo and I can see the composite there. It's just gone in, removed a bit, and then gone on with my bonding steps. This another one that shows the power of photos. So this patient came in for an emergency appointment for her 6 because the cusp fractured off. What do we say before? Oblique cusps and oblique cracks. Eventually the cusp will just fracture off, right? And that's what's happened here. It's almost like the prep's done for me in that area. But as soon as we took that photo, I pointed this crack out to her, and quickly the conversation went from not even knowing there was an issue to, oh, how do we fix that crack, right? And just like that, we're doing now a partial coverage on this tooth here. Tricky one about this is the roots of these teeth were extremely close together. So you'd see I was getting closer and closer. The prep, I've got some flared exit angles, which is what we want. We don't want those that box to be quite narrow. We want it to be quite wide. It helps it insert as well, because as you insert, the composite comes out the sides as opposed to being stuck in the contact. But even though these look nice, you can see here the issue that I had, right? And it's the fact that there wasn't enough separation here. So I had to go back, just cut that out again and rescan. I could have probably gotten away with that and just polished the ceramic, but we want nice margins there. This is an example of what I was talking about before with scanning, where we kind of stitched the rubber dam scan to the existing scan. So it worked quite well here. And it means I didn't have to deal with bleeding gums or anything. I just had my beautiful rubber dam retraction ready for me to scan. Got some partial coverage action here. These are really fun to do. Got a peripheral rim fracture here, decay under that, but clean marginal ridge here with a patient with otherwise good hygiene. That's where I'm doing partial coverage here. Super easy to prep. And this is a case I did more recently. You can see some of those enamel cracks that I ended up just leaving, right? Because enamel cracks are biomimetics and they stop at the DEJ and they're not extending in. Remove some of the pins where we don't use GI liners anymore. They don't bond very well, kind of like a trampoline under the unbonded area, and they also increase fluid movement. So removed all of that, removed any of the decay in that peripheral seal zone. And you can see this vertical crack towards the back where I stopped. I troughed a little bit in this area, opened that area a little bit, and then we called it a day, right? Show them to the patient. Patient understands, we're all good. And these are the final ceramics here. Now, very quickly, just before we finish, just 2 cases left. We've got some direct cases here as well, because all of these principles, especially that dentine bond maturity and the steps and the isolation, all of them still play a part in direct restorations, right? Now, this patient, I booked back the day after I got back from a pretty long trip, and I was quite sad when I got back and I saw this, but we did it. Took a while. If you're looking for the clamp on that tooth, you can see there's no clamp. We're using a circumferential matrix, in this case, the Gerges matrix B1, to hold the rubber dam down. And then what I did is I used the matrix in matrix technique, where chop up another sectional, shove it in. The Gerges matrix is a bit shorter than it's a lot shorter than a traditional Toffelmite, because it is a margin elevation matrix. So because it's a bit shorter, I could flare that sectional out a bit wider. I've used some tacks of flowable here on the next door tooth. And then once I did that, I could just polish it back with a disc before I did this side, right? But you can see that pretty large gingivectomy we did there. I used the electrosurgery for that. In hindsight, what I probably should have done was lob off these cusps and this cusp here. Would have been a really nice indirect case to do as well, maybe with indirect composite. But we're going to do these with ceramic at some point in the future. And you can see that kind of seal there on this side as well. And then this side we just restored like normal. And those are those final bite wings there. And a bit of an explanation of how I do this. It's on my Instagram as well. And that's the paper that describes the matrix in matrix technique. Don't use it much anymore, because now I've got the Gerges matrix. That they've got 2 types that do different things. And final case, these kind of situations can help with areas where maybe surgery, crown lengthening is not an option, or patients can't get extractions. This tooth's pretty cooked. Root canal's been exposed for a while, had an old crown on it that came off. And what we needed to do, patients like 95, what we just needed to do was stabilize this enough. The patient unfortunately passed away recently as well. But it got them through till the end. What we did is we did a pretty hectic gingivectomy around the sides, probably a little bit brazen in that area, to be honest with you, but it's fine. We left a bit of composite there because it wasn't staining, and it was going to help hold the matrix. And you can see even here, I saw, I took that picture. It looks really sealed, but I saw this image and I could see some liquid in there. I wasn't sure if that was from my selective etch or my air abrasion, or whether that was seepage. So all I did was tighten the matrix a bit more, spray some air, watch it for a little bit, and then moved on when it was nice and sealed. And that's the final one, all right? And that's pretty much it. Thank you for listening for 87 very long minutes.
Hello, yeah, amazing. Very thorough, very in-depth, Dr. Addy. Thank you so much for that. And thank you for those who have managed to stay all the way to the end of the didactic part here. We do have a few questions here, but before we'll give anyone else who has some questions to send them in the chat. And while you guys are doing that, I'm just gonna do some. Just mention that we do, as at GDR, we do have we run some programs. Our core program is the residency. It's a mix of hands-on, live in person, and online mentorship. So our next cohort is in August. We have a early bird offer. So if you sign up by the end of the month, you'll get $3,000 worth of bonuses. So including a restorative kit, you'll get some polishing kits from Ultradent, access to a CEREC Jumpstart module, and access to a photography workshop from Sabi Hunt, who is a lab ceramist. So check out our website for more information. Now, we've got some questions here. We'll pop them on the screen and as we go through here. So the first one from Illuminati. How is BAD's philosophy that different from the ADA's ICCMS?
Well, honestly, it's not really different. I mean, the ICCMS is just a classification system for caries, right? And to be clear, a lot of the concepts here, we just teach them at BAD, and so does GDR to some extent. They're just kind of a conceptualization of a lot of the papers that I mentioned, right? And these are ways to objectively approach these areas, or this caries removal. The ICCMS is simply a guideline of how to classify these. Do both, right? They've got some treatment recommendations, but from memory, they rely on radiographic and clinical appearance. But I'm not sure they talk much about caries detector dye. I think there's a lot of tactile feel, and the question always is, how hard is too hard? When the Japanese were talking to the Europeans, that was always the question, right? And one of their students asked them, and that's when they went and developed caries detector dye, and that's why we're here. So, yeah, I hope that kind of answers that question. We use both. It's fine.
You can use a bit of both, yeah. Make your own judgment, yeah.
Exactly.
Dr. Makawi, could you please reference the paper that states that bond strength?
All right, my man. Let's have a look at the screen.
It's higher than enamel.
Where are we? We've got quite a few, but we've got the Van Meerbeek one for sure. Where are we? Here we go. Yeah, so we've got the Van Meerbeek one. We've got quite a few others, to be honest. We've got Urabe. We've got a bunch by Manier. But this Van Meerbeek one is one of the bigger ones that's cited quite a lot because it was one of the first ones. There's been a ton of follow-up ones since then. I know Gresnik, Milicis has done a bunch, and we hear about him more because he's based in New Zealand as opposed to in all the big countries. Gresnik's done a ton on veneer IDS as well. And that's even more important because, at least with posterior overlays, sometimes you can have a little bit of, not retention, but you can have a bit of resistance form, right? The veneer is the true kind of non-retentive prep because it's purely relying on adhesion. And Gresnik's got a bunch on dentine sealing that and how that can improve. I think 50% dentine exposed in your veneer prep, especially if you're replacing veneer preps or veneers, you seal that dentine, essentially has the same strength as a fully enamel prep. At least that's what they found across the board. Very general statement. Hope that helps.
Amazing. All right. Regarding this is from Dr. Sam Khan. Regarding the peripheral seal zone, where is 2 to 3 millimeters measured from?
Yeah, cool. Let's go to that picture. Where are we? Is it this guy? Where is that? Yeah, so the peripheral seal zone is just measured from the periphery of the, so it includes, I think what you're asking is it just the dentine? Is it measured from the DJ, or is it measured from the outside? It's measured from the outside of your prep. So it includes all the tooth structure, right? but that central stop zone, that kind of pulpal limit, on average, it's like 3 millimeters away from the adjacent marginal ridge, 5 millimeters down from the kind of cavo-surface angle or the cusp tip. It's a good stopping zone for the pulp, to answer your question just from the outside.
Thank you very much. We've got Dr. Mia Ward. Do you use Gluma when doing IDS?
No, not really. I think it's a desensitizing agent. Don't really see the need for it, really, especially because we're getting the strongest bond after IDS. Gluma, I don't want to blanket statement this, but Gluma in some cases can kind of be like hiding the fact that you've got issues there and hiding the desensitizing or hiding the sensitivity that you're getting from, cracks that you've left behind after a traditional crown prep. It's good for you and good for your patient for a little bit, but that crack's still there, right? Use Gluma. It doesn't hurt from what I know. I'm not sure if there's any kind of harms, but there's just no need to use it. You get a very good seal with IDS. A lot of my inserts, I don't use LA. If I do, it's on the clamped tooth, not on the actual tooth that I'm inserting, because the tooth's not sensitive anymore. We've sealed all the dentine, right? But use it if you want. We just don't really see the need to. You save a bit of money if you don't get it.
Unless you're an associate.
Yes, exactly.
We've got Dr. Brendan. Yeah. Do you usually use rubber dam for your DMEs?
Yeah. So, look, like I said before, especially when we're deep margin elevating, we want absolute gold standard isolation. Look, there are some situations, some rare situations where I'll have a patient, or I'm running late, or they're an emergency patient, or something or the other. There was one where I had to use the Gerges V2 matrix, which is a single-sided one. It's for very deep single proximal areas as opposed to circumferentially. That was the first one in a while where I split dammed, got that guy on because I could see bone down there. So we were a little too deep. But ideally, especially if I'm comfortable enough putting a ceramic on it, I'm using gold standard isolation. We're doing full rubber dam because we want to bond to that poor quality dentine as best as possible.
Very good. Yeah, I'll also try to do DME under rubber dam as much as possible. Worst case, yeah, split with a bit of Teflon or something.
That's
just
it.
anything. We've got Dr. Kaur here. How long do you heat the ceramic for? I think this is with the when using the that heater device.
Yeah. So look, with the BAD heater, I'll heat different things for different amounts. With the ceramic, I'll just keep it in there for as long as it takes me to do my tooth steps. So for example, ultrasonic baths on, I chuck my rubber dam on. While I'm chucking my rubber dam on, ultrasonic bath finishes. We then go back to the ceramic. We'll primer and salinate everything, and we'll chuck it in the heater. And in the time that it takes me to do my tooth air particle abrasion, my primer on my total etch, my primer and my bond, ceramic's now hot, right? However long that takes. The one thing I'd be careful of for you guys that are going to go ahead and use a heated packable microhybrid composite, like we talked about, definitely practice before. It's quite technique sensitive. I'd rather use a resin cement or flowable if you start off with. If you're going to use a heated packable and you're going to use Clearfill APX, it's definitely the one with the most research behind it, but it has a really weird heat activator thing in it that after a minute or two at 100 degrees, it can start to set on you. Don't ask me how I found that out. So there's no known reason. Talk to Pascal as well, Manier, and he has no idea why that's in there. It's kind of why there's a shift towards some other composites now, like Z250. Don't use Filtech Supreme. Sorry, I know we're not meant to talk about brands and stuff, but Z250 is good. Supreme, not good. But in terms of how long you heat the ceramic, just depends on how long that is. Just be careful if you're putting the heated packable in it, don't heat it for too long. Otherwise that clear fill APX might start to set.
Very comprehensive answer. And you can talk about brands, it's fine. It's
Yeah.
not a big deal. We've got some questions from Dr. Audrey, but we'll go to Ginny first.
Yeah.
Hi, Dr. Addy. Which matrix do you recommend for your DMEs?
Yeah, so look, obviously I'm biased here because I teach with the guy, but Bill Gerges he's the founder of BAD or BAD. He invented the ultrasonic bath, bad heater, and a bunch of deep margin matrices. Honestly, the reason I got attracted to it initially is when I was back at uni, he had a post on his Instagram about how to cut a standard Toffenmeyer for deep margins. And my boys at uni and I would like do that. And we had a couple set up in the tray. And our tutors didn't see, and then we just used those when we needed to. And then he developed the actual deep margin matrix. Biggest reason I started using it, and I bought it myself before I started working with him, is because it is way cheaper than everything else. Garrison has a deep margin matrix. Bro, you have to be so rich to afford that regularly. There's absolutely no chance. A couple of others around the market, but Gerges Matrix is very affordable. And now these got V2, which targets different sides. It works even better. You just search Gerges Matrix, Brickworks Dental, and you'll be able to source that one. Or just message me on Instagram.
Everybody message Dr. Addy. Okay.
Just a little note, even if we don't answer all these questions, because there's quite a few, just chuck me a message and I'll start sharing the answers on my story and we can go from there. It's not an issue.
Yes, and guys, please, if you have taken photos or whatever, you have some thanks, please post it on your Instagram and tag us on your story.
True. James, how many people do we still have?
We're down to 63 now. So
all right. Take any pictures of anything? Did I say this at the start? I can't remember.
You mentioned you were going to give away. You mentioned
yeah. So make sure you post those. I still haven't figured out what. Maybe some matrices or maybe something else. We'll give away something to 2 people, and we'll do like a little draw of anyone that tags me and GDR. And we'll do a little kind of raffle and we'll figure out what we're going to give you. But 2 people. Yeah, let's go to the next question.
All right. We got Dr. Audrey Yee. Is there no additional benefit of re-sandblasting the ceramic after trying it in?
So just to clarify, we don't want to sandblast the Emax at all. Zirconia is different. If you're bonding that on, that can actually help quite a bit as per the APC protocol by Marcus Blatz. But with Emax or any glass ceramic, that even goes for feldspathics and things, you do not want to sandblast the ceramic at all because it can introduce micro cracks. We're getting that kind of bond from the ceramic etching, but you don't want to sandblast your glass ceramics. So yeah, try not to do that. You'll introduce micro cracks and increase the chance of cracks of that ceramic in the future.
Don't want cracks. Okay, second question. Coming back to packable composite. How do you not putting too much, i.e. changing the occlusion?
Yeah, that's it, right? So can you guys, oh no, you can't see my slides. That's all right. We don't need to.
Oh, no, give it back up. Give it back up. Yeah.
All right, let's go back to that lab prescription. Where is that? Again, I don't send for single or like quadrants and stuff. I mostly use the CEREC, but use the lab. You can see we've got, there we go. Got a bit of a bigger spacer, especially like I said, for heated packable, right? So with heated packable composites, that bigger spacer will fit that heated packable. But that's why I said we want to use a micro hybrid heated packable composite. So good examples for brands, Clearfill APX, like I said, and I think it's Filtex Z250. The reason we want a micro hybrid is other types of composites, they have kind of fillers in them or particles in them that are a little too large, and they actually won't squash down to that spacer limit. And even though we've got 100 to 120 micron spacer, it's not going to be that thickness everywhere, even from the lab perspective. But from our perspective, our squish accuracy is not going to be that perfect, right? We're only human. So, you're going to have the same kind of discrepancy you probably would with any other cement, as long as you use those heated packable ones and you actually heat the composite up. I hope that kind of answers the question.
Hopefully. This is the last one from Dr. Audrey. Just checking, you're mentioning the most convex part of the tooth.
Yep.
You bevel the enamel, but underneath you just do a flat butt joint.
Yeah, pretty much. So if you look at the picture on the screen here, this is probably the maximum convexity of the tooth. Above, I would bevel. And that's because the kind of surface area the prism's exposed is going to be better. If you're kind of got a load perpendicular to, these are your prisms, you've got a load perpendicular to it, it can tolerate that load about half as much as what the research shows. It's like 11 versus 25 versus beveling the enamel and having the kind of load parallel to those prisms. So bevel that a bit above the height of contour. Below, we start to get a bit of irregular prism structure. Things actually become a bit more unfavorable if you bevel them. And you can see the enamel gets thinner under that height of contour, right? So if you start getting here and then you bevel that, you're actually starting to lose a bit more enamel. You might even get somewhere down here where you just like, you're beveling dentine at that point. So just use a butt joint down there. I can't remember if I mentioned this or not, but in terms of what layers we like to keep covered with the resin coat, don't cover that bevel as much as you can. But if you go over a little bit, that's fine with your resin flowable layer. But cervical enamel, that really cervical brittle enamel, which is sometimes unsupported and quite thin, I tend to favor covering that with flowable because it's going to reinforce that brittle cervical enamel. Anyway, long answer to that question.
Let's go to Jay. Thanks for the amazing lecture. When aeration is unavailable, you could use a yellow football burr to roughen the prep. I think you said this right. Prep, but would it risk removing the IDS that we've done previously?
First of all, Jay, thank you for saying thank you. It's quite nice. Yeah, you're right. You can use a yellow football burr to roughen up the prep. Look, people in the past have also used pumice and things, but the kind of, you get like, or air pumice, you can get like a 15, 20 MPa strength between the ceramic and the IDS layer if you're using just pumice, but that's going to be a huge weak link, right? If you're using the yellow football burr, at least you're roughening that prep up area. And if you foresee yourself using the yellow football burr, you're very right. It will risk removing the IDS that we've done previously. That's why air abrasion is just better. Get a unit. But that resin coat that you're doing over the top, that is thickening up that IDS layer, right? Like suddenly from, the adhesive that you put on might be as thin as like 5-10 microns. Now you've got a 500 micron layer. With your flowable, you can even put a bit of composite over the top for deep margin elevations. That's exactly what it is. You've got your adhesive, got a bit of flowable, and then you're elevating the margin. You've got more packable. If you feel like you're going to have to use a yellow football, just thicken up that layer a little bit more. And that way you don't risk losing any of that IDS layer. Keep everything kind of sealed.
Very nice. And speaking of IDS, we have another question from Lisa.
Cool.
Can you go through the IDS protocol?
Awesome.
Stage?
Let's go to the IDS slide. Here we go. All right. So in terms of, it will highly depend on the adhesive that you're using. When we get into some of these nitty gritty things, that's where a course is a bit better to actually do it. But with the actual steps, if we're using a self-etch 6th gen system like Clearfill SE, what I tend to do is I don't want to over-etch the dentine. You guys might have learned in uni, you can over-etch the dentine fibrils and the collapse of those fibrils. One thing that does help with the self-etch system is air particle abrasion. So With Clearfill SE, which I use the most, I'm air particle abrading that with 50 micron aluminium oxide. One thing that air particle abrasion does also do is, it's a bit more theoretical, but not only does it remove the smear layer, the little bits that are created from your burrs, it's actually, let me just double check this. I believe it's the intratubular dentine, the stuff inside the tubules. It's packing all of that. And the intertubular dentine, it's packing smear into that area. And the intertubular dentine is actually exposing it for bonding. What that does is an additional benefit is it additionally blocks fluid, pulpal transudation from coming up into your bonding layer, right? So air particle abrasion there, and that way you get a mild etch of that dentine using your self-etch system. So primer, scrub. Sometimes I put a second layer if I'm feeling super extra. Air dry that because we want to air dry the solvent. All of our primers have solvents in them. And then put my bond over the dentine, go over the enamel a little bit. It's no biggie. You can always polish it later, but I want to make sure the dentine's sealed. Cure that. Then I'll put my Clearfill Majesty ES Flow or any flowable you want. I'd recommend using a flowable that's self-leveling. It's a bit thinner. Genial Universal Injectable is great for some things. It's not great for this in my experience. It's really thick. It's horrible to polish. Yeah, just don't use that. Decent for actually cementing your overlays after, because it's got high filler content, but not for the IDS layers. Use a thin flowable layer, put 0.5 millimeters. In that first 5 minutes with the dentine bond timing, general rule that like Simone Delaperi and the Allemans came up with in their papers is try not to thicken up that layer more than 1.5 millimeters in that first 5 minutes. Now, are you going to sit there and measure 1.5 millimeters with your probe? No, that's a waste of time. Just approximate it, right? With OptiBond FL, a bit different. That Van Meerbeke study that I showed before actually shows that just roughening up with like a diamond, so just your regular prep, is actually a bit better than air particle abrasion. What air particle abrasion still does though, for even a total etch, is cleans the whole surface. So what I do if I'm using OptiBond, air particle abrade everything, then just roughen up that dentine a little bit with a slow speed burr, and then total etch for 15 seconds, primer and OptiBond FL bond. Because FL is a lot thicker, we're getting kind of past that oxygen inhibition layer. So you can either add another layer of OptiBond FL flowable or some actual flowable resin on top of that and cure. After all of these steps, whichever one you use, you want to chuck glycerin over the top or some kind of clear medium and cure through that to get rid of that oxygen inhibition layer completely. The last thing I'll say is if you're taking a physical impression, PVS can interact with some of these resins. So over-engineer this and just pumice the prep as well. Same thing goes if you're doing a temp, because you'll stick a temp on once with these guys and you'll never do it again. So over-engineer getting rid of that oxygen inhibition layer. Pumice it, alcohol wipe it, do everything you can to it, and then you can make your temp.
Yeah, I think we will have to go to that problem once when you make a temp and it sticks to the prep.
That's it. Actually surprised no one's asked how to make a temp, but that's a large question. So
I reckon someone wants to know out there.
Someone wants to know? Okay, all right.
How do you want to make a temp? How do you make a temp?
Like I said, over-engineer not bonding to that IDS layer. You know, we'll prep it later. You know, at insert, we'll air particle abrade, we'll get it super bondable again, but we want to make it super hard to bond to when we're up to that temp stage, right? One way to temp is not to temp at all, right? And that's what we do with the CERECs. It's the easiest way to go about it. CEREC dentistry goes hand in hand with overlays. It's just a beautiful thing. If you've got patients coming in like the next day or in a couple of days, pretty easy way to do it, it's a bit like bare bones, is get a bit of liquid dam and just put it in the proximals. And what that's doing is, you know, all the dentine's sealed, so the patient's not going to be sensitive as long as you've done it correctly. But putting that liquid dam just in the proximals of the teeth. So if I've got my prep here, chuck a bit of liquid dam here and here. It's just going to stop the teeth adjacent from moving closer. That is like a real ghetto way of doing it. Like it's super, not. It's only if you just have no time, right? Better materials. There's materials called Clip. There's a material called Clip. There's another one called Tempet, which is a bit cheaper. It's Telio Onlay. What they are, they're just like these clear resin things that you squash on top of the prep, get the patient to bite, you get a bit of occlusion in there, and you cure. And it's just something you can peel off later. It gets into the undercuts a little bit. If it's a really non-retentive flat prep, what you can do from like after you've squished and cured that guy on, you can also draw little flowable arms, kind of like I did. Where is that hooked crown case? This guy here. Kind of imagine if my temp was on the tooth and I drew little flowable arms and spot etched and bonded on the next door tooth or further down the prep tooth. So what I mean by further down is like, let's say this was a temp, squished my tempet on there, drew a little flowable arm down here and spot etched and bonded down here. Then I could just draw some flowable arms. It would stay on. Other thing you can do, what we call at BAD, the potato method, just get a bit of Pro Temp, squirt it onto the tooth. Looks like a potato after it's set. Adjust the occlusion as much as you can, clean up the contacts a bit, put it on, and then you lock it in with some flowable arms and things around the side. You just make sure it's out of, like mostly out of occlusion or just in occlusion. And that will generally get you by. What I'd say is if you are spot etching and bonding somewhere else, just don't spot prime. That can make things a bit more permanent. And you could also spot etch the prep, just like you do with veneers, but I don't really like doing that because it just increases my stress at insert at getting the whole thing off. So, yeah.
Awesome.
Answer the question no one asked.
Yeah. I get this question a lot from people who want to get into onlays, but they just don't believe they would work in their hands. Do you have any advice for these people who want to move away?
Sorry, you just cut out there. So people that have heard of onlays or overlays but don't think that it'd work in their hands?
Yeah, they don't know if they're scared that's because it's non-retentive. That's not going to stick and it's going to fall off. What words would you give to them?
One thing I'd say is there's so much research since the 80s, but now like a ton of clinical research. I think I remember asking one of he's definitely not on here. He's like a retired now, but one of my profs at uni, I asked them about DME. I still remember that. I got quite a rude email back, and a lot of people, and I can't blame him, right? Even the biomimetics and the super retentive people and everyone in between, everyone's super culty about everything. But all you have to do is look at the research, right? I'm not going to say I never prep a traditional crown. There are definitely situations that I do, and there's definitely situations, more importantly than that, where I'd still recommend crown lengthening over deep margin elevating because it's not quite a full alternative. But what I'd say to these guys is you can see the research here. Go do your own research as well. Believe in the bond. Clearly, it works. But more importantly than that, I am, like I told you, I'm super lazy, right? And the best thing about these preps is they're kind of like doing a crown prep. You do the occlusal reduction, and then you just stop, and you're like, oh, all right, I'm done, right? And then take some pictures. Rubber dam's easy because it's not subgingival. You don't have a equigingival prep. Patient's happier because I've just had less complications since doing this type of dentistry. Yeah, I mean, it's kind of where I'd start. If you're really concerned, and obviously, if you want to get some hands-on practice, go to one of GDR's courses. They do some onlay overlay stuff, and obviously us at BAD, we've got a couple of dates in Perth, Sydney, and Brisbane. But yeah, just honestly start prepping some of these on a model in your clinics or just grab an extracted molar. myself and even the other boys at BAD and James, and I have to credit Dr. James and Dr. Alex as well, are so open. So with kind of advice and stuff with cases. So just reach out to one of us and we can help you through a case as well. It's not the end of the world, but course is always good.
Yeah, definitely try a course and get believing. Get believing. I think that's it for the questions. So just a nice thanks from Chris.
Thanks, man. Appreciate it. It's very nice.
And Audrey following up saying thank you for the answer there. So we've just hit the 2-hour mark. Congratulations to the 45 people who are still on or have fallen asleep, most likely. Probably dreaming about Pitbull or something like that.
Yeah, true.
So
think of the Pitbull.
I'm going to be thinking about Pitbull, that's for sure. Thank you all for coming. And that's the end of our webinar series for this year. So keep an eye out for our next year for our next series. And if you are thinking about the August cohort, please sign up. And if you're thinking about the BAD courses, do give it a go. It's quite a good course as well. So again, thank you all for coming. Thank you for your time.
Thanks, guys.
See you all. Bye.